3.1 Introduction. Academic counselor Dr. Mahima was happy that the learners were taking great interest in various psychological disorders. The next disorder that she was supposed to discuss was personality disorders. Therefore, in previous class asked the learners to find out what personality disorders were. Dr. Mahima: hello learners. Learners: hello ma'am. Dr. Mahima: I hope all you read about personality disorders. Learners: yes ma'am. Dr. Mahima: so who will tell me in brief what personality disorders are? Seema: learner, personality disorders are related to one's personality structure. Dr. Mahima: yes Seema, you are right. In BPCC 103, we discussed about personality, and as the name suggests, the personality disorders are related to personality. Rizwana: learner also ma'am. Personality disorders are a heterogeneous group of disorders and are characterized by problems in forming a stable positive sense of self and sustaining close and constructive relationships. Dr. Mahima: absolutely right Rizwana. But can anyone tell me how it is described in DSM-5? Seema: learner, according to DSM-5, an individual is diagnosed with personality disorder if there is significant impairment in self, identity or self-direction, and interpersonal, intimacy or empathy, functioning. Navgeo: learner also ma'am. DSM-5 categorizes personality disorders 3 clusters on the basis of important similarities amongst the disorders, namely cluster A, B and C. Dr. Mahima: I should say that I am very impressed by the way you have studied about the personality disorders. So let us further discuss what the personality disorders are. From the above discussion between Dr. Mahima and the learner, you must have developed an idea about what personality disorders are. In the present unit, we will explain the characteristics and classification of personality disorders and will also describe cluster A, B and C personality disorders. 3.2 Defining personality disorders. Personality of an individual can be understood as a set of unique traits and behaviors that describe and characterize the individual. These typical traits, coping styles and behaviors usually emerge during childhood and then become established patterns by early adulthood. These characteristics or blend of characteristics make a person unique. The continuity, constancy, consistency and stability of these traits and dispositions over time define personality development. It has also been agreed upon that the 5 trait dimensions, neuroticism, extraversion/introversion, agreeableness/antagonism, openness to experiences and conscientiousness can be used to define personality. The personality disorders are a heterogeneous group of disorders. They are usually characterized by problems in forming a stable positive sense of self and sustaining close and constructive relationships. According to DSM-5, a person is to be diagnosed with personality disorder if there is significant impairment in self, identity or self-direction, and interpersonal, intimacy or empathy, functioning. The person's enduring pattern of behavior must not be flexible and should be pervasive, stable and longer in duration that deviates from the individual's cultural expectations. It should cause clinically significant distress or impairment in functioning in various areas of life and should be manifested in at least 2 of the areas: cognition, ways of perceiving self, others and events, affectivity, range, intensity and appropriateness of emotional response, interpersonal functioning or impulse control. It has been understood and agreed upon that people with personality disorders cause difficulty in their own lives as well as that of the others. Others usually find their behavior confusing, unpredictable, vexing and also unacceptable at times. The pattern that they have developed over time color their perception totally, thus determining their reactions to newer events and situations in the same light, repeating their maladaptive patterns over and over again. The category of personality disorders encompasses a broad range of behavioral problems which may differ in their form and severity. DSM-5 categorizes them into 3 clusters on the basis of important similarities amongst the disorders. Cluster A, it includes paranoid, schizoid and schizotypal personality disorders. These disorders involve thinking and behavior which appears unusual, odd and eccentric to other people and may often lead to various social problems. It may range from distrust to suspiciousness and even social detachment. Cluster B, it includes histrionic, narcissistic, borderline and antisocial personality disorder. These disorders involve tendency of the individual, diagnosed with it, to be dramatic, erratic, unpredictable and also emotional. Cluster C, it includes obsessive-compulsive, avoidant, and dependent personality disorders. These disorders involve tendencies to be anxious and fearful. Box 3.1, difficulties in diagnosing personality disorder. Diagnostic criteria for personality disorders is neither sharply nor clearly defined as they are for other diagnostic categories. A lot of judgment is required on the part of the clinician as the criteria for personality disorders is defined mainly by inferred traits or consistent patterns of behavior rather than objective behavioral standards. Some of the personality diagnoses are not very common in the community setting or even most clinical settings. They are found in less than even 2% of the patients. Many people who may seem to have some personality-related issue may not fit any of the personality disorder categorization or diagnosis in particular, thus, the dimensional approach is the best suited here. Research suggests that people diagnosed with personality disorders at one point in time when interviewed after 2 years qualified for another diagnosis, though they may have some of the symptoms of the previous diagnosis. Diagnosis made on the basis of structured interviews or self-report inventories have been found to be low on reliability and validity. A unified dimensional classification has been emerging and attempt has been made to integrate various existing approaches in order to make the diagnosis more reliable and accurate. The most influential of them being the 5-factor model based on 5 basic personality traits. Within the dimensional approach, an attempt was made to recast the personality traits to correspond to the pathological extremes: negative affectivity, neuroticism, detachment, extreme introversion, antagonism, very low agreeableness, disinhibition, very low conscientiousness. Psychoticism was not found to be the pathological extreme of openness, rather it reflected traits similar to psychotic disorders. Schizotypy. Box 3.2, difficulties in studying the causes of personality disorder. Personality disorders did not receive any formal attention till they were added in DSM-3 in 1980. Thus, the work itself began later in comparison to other disorders. A major issue is that a high level of comorbidity is found among them. Zimmerman and his colleagues reported that almost 45% of the 900 patients, their sample, qualified for at least one personality disorder, and out of these, 45%, almost 60% qualified for more than one and 25% qualified for 2 or more personality disorders based on the given clinical criteria. Due to the high levels of comorbidity, it gets difficult to conclude which causal factors are associated with which particular personality disorder. Researchers were found to have more faith in the prospective studies. People are observed before a disorder occurs and are followed to see who develops what problem and what could be the possible reasons behind it. However, a vast majority of research is conducted on people who already have the disorder, so understanding is based on either the retrospective recalls or current observation of biological, emotional, cognitive and interpersonal functioning. Thus, the conclusions could be very preliminary and tentative. Infants' temperament may predispose them to development of a particular trait and thus a disorder in consequence. It lays foundation for development of personality as an adult, but other factors may also be responsible for it. For most disorders, it has been found that the genetic contribution is mediated by genetic contribution to primary trait dimension most implicated in each disorder rather than to the disorders themselves. Researches are being attempted to understand the psychobiological layer of the traits mainly seen to be involved in personality disorders, with the ultimate goals of reaching an enriched biopsychosocial understanding. Apart from these biological causes, psychoanalytic, learning-based models, cognitive patterns, attachment styles, social patterns, cultural values etc. have also contributed to the understanding. 3.3 Cluster A personality disorders. The main symptoms of cluster A are social awkwardness and social withdrawal, dominated by distorted thinking patterns. It is also known as the odd, eccentric cluster. People falling in this cluster may display unusual behavior, for instance, suspiciousness and distrust as well. In cluster A, we will discuss paranoid, schizoid and schizotypal personality disorders here. 3.3.1 Paranoid personality disorder. Being wary of people, questioning their motives is not very uncommon and can also be adaptive. But, being too distrustful and questioning anyone and everyone each moment can impact relationships. It can interfere working with others or in groups, with making friends and many other aspects of life which involve interaction with people on a daily basis. They usually assume that people out there, in the world, are to harm or trick them and thus they do not confide in them. The defining feature of this disorder is the persistent unjustified distrust. People with paranoid personality disorder usually get suspicious even in the situations where most people would find their suspicions to be unfounded. They may interpret the events unrelated to them or remotely related to them as personal attacks on them. This makes their interpersonal relationships very difficult and strained, as this distrust often extends even to the close family members. They see themselves as completely blameless, instead they put the blame on other people, guilty even for their own mistakes and failures. Thus, they may always look on guard and expect trickery from others, which forces them to look for cues to validate their false expectations. They are usually argumentative, may complain or may remain quiet, but are commonly seen to bear grudges, refuse to forgive insults that they may have perceived, and may also get violent. They are in touch with reality, although may experience certain transient psychotic symptoms during stress. Also, they are more likely and liable for schizophrenia. Box 3.3 DSM-5 Criteria for Paranoid Personality Disorder. A pervasive distrust and suspiciousness of others such that their motives are interpreted as malevolent, beginning by early adulthood and present in a variety of contexts, as indicated by 4 or more of the following. 1. Suspects, without sufficient basis, that others are exploiting, harming, or deceiving him or her. 2. Is preoccupied with unjustified doubts about the loyalty or trustworthiness of friends or associates. 3. Is reluctant to confide in others because of unwarranted fear that the information will be used maliciously against him or her. 4. Reads hidden demeaning or threatening meanings into benign remarks or events. 5. Persistently bears grudges, that is unforgiving of insults, injuries, or slights. 6. Perceives attacks on his or her character or reputation that are not apparent to others and is quick to react angrily or to counterattack. 7. Has recurrent suspicions, without justification, regarding fidelity of spouse or sexual partner. B does not occur exclusively during the course of schizophrenia, a bipolar disorder or depressive disorder with psychotic features, or another psychotic disorder, and is not attributable to the physiological effects of another medical condition. Note: if criteria are met prior to the onset of schizophrenia, add premorbid, that is, paranoid personality disorder, premorbid. Causal factors: the evidence of biological contribution to paranoid personality disorder is very limited. Arguments have been made about the partial genetic transmission linking it to schizophrenia, but there are no conclusive or consistent researches pointing at the same. Researchers have also suggested that this disorder is slightly more common amongst the relatives of people with schizophrenia, although the associations are not very strong. It may also occur through the heritability of high levels of neuroticism or even antagonism, traits in paranoid personality disorder. As far as psychological contributions are concerned, retrospective researches suggest that mistreatment or and traumatic childhood could play a role in development of paranoid personality. Parental neglect, abuse and exposure to violence could also be responsible. Freeman and colleagues discussed some basic faulty and maladaptive assumptions these people may have about others. People are malevolent and deceptive, they'll attack you if they get the chance. Some researchers have pointed that these assumptions are built due to their early upbringing, as they are asked to be careful, vigilant and on their toes all the time. Certain cultural factors have also found to be playing role in paranoid personality disorder. Groups of people, such as refugees, prisoners, older adults, are considered to be susceptible to this disorder due to their unique experiences. Cognitive factors may also interact with cultural factors. For instance, a refugee with language barrier who is looked at differently by others may always be suspicious and wary of people around them. Treatment: one of the major impediments in their treatment is their distrustful relationship, due to which they are unlikely to develop a warm, trusting and meaningful relationship with their therapist. If they go and seek treatment, it is usually due to some other problem they might be facing, like depression or some sort of anxiety. It is rarely due to their personality issues that they would seek treatment themselves. Cognitive therapy is widely used to challenge and counter their faulty thinking patterns, with an emphasis on changing the belief that most people cannot be trusted and most people are there to harm them. Still, there are no confirmed demonstrations that any form of treatment could significantly improve the lives of people with paranoid personality disorder. 3.3.2 Schizoid personality disorder. The term schizoid was used by Buehler in order to describe people who had a tendency to turn away from the outside world. People with schizoid personality disorder demonstrate a pervasive pattern of social detachment and an extremely restricted range of emotional expression, and thus remain socially isolated. They do not usually seek out for relationships on their own, and are most often cold, aloof, and indifferent to people around them. People with schizoid personality disorder are not interested in maintaining close relationships with others, neither romantic nor sexual relationships. Thus, they appear to be cold, distanced and detached people who are neither affected by praise nor by criticism. Homelessness also appears to be common in these people. The social deficiencies found in people with schizoid personality disorder are more extreme as compared to individuals having paranoid personality disorder. They consider themselves to be observers rather than participants in the world around them. They appear to be socially inept and superficial due to their indifference towards social cues and nuance, and are often classified as loners and introverts. Here, it is very important to mention and emphasize that all loners or introverts are not people with schizoid personality. As they are not emotionally reactive, they rarely experience strong emotions, positive or negative, rather they show apathetic mood. On the 5-factor model, they show high levels of introversion, being low on warmth, positive emotions and gregariousness, low levels of openness to feelings, and are also found to be low achievement striving as well. Like the other two disorders of cluster A, the thought process of individuals with paranoid personality disorder is not that unusual. Box 3.4, DSM-5 Criteria for Schizoid Personality Disorder. A pervasive pattern of detachment from social relationships and a restricted range of expression of emotions in interpersonal settings, beginning by early adulthood and present in a variety of contexts, as indicated by 4 or more of the following. 1. Neither desires nor enjoys close relationships, including being part of a family. 2. Almost always chooses solitary activities. 3. Has little, if any, interest in having sexual experiences with another person. 4. Takes pleasure in few, if any, activities. 5. Lacks close friends or confidants other than first-degree relatives. 6. Appears indifferent to the praise or criticism of others. 7. Shows emotional coldness, detachment, or flattened affectivity. B. Does not occur exclusively during the course of schizophrenia, a bipolar disorder or depressive disorder with psychotic features, another psychotic disorder, or autism spectrum disorder, and is not attributable to the physiological effects of another medical condition. Note: if criteria are met prior to the onset of schizophrenia, add premorbid, that is, schizoid personality disorder, premorbid. Causal factors. Extensive research is yet to be conducted to understand the genetic, biological and /or psychosocial causal factors to schizoid personality disorder. Some theorists and researchers are of an opinion that the disruption in sociability could be due to some sort of impairment in the affiliative system. Childhood shyness may also act as a predispositional factor to schizoid personality disorder later as an adult. Childhood abuse and neglect have also been reported in the retrospective studies among the individuals with this disorder. Some researchers have also indicated that parents of children with autism are likely to have this disorder. There is a possibility and a particular biological dysfunction may play a role in both autism and schizoid personality disorder, and that gets combined with some early difficulties like aspects of interpersonal relationships which impact the social interaction of the individual. Cognitive theorists have suggested that the maladaptive schemas of these individuals lead them to be self-sufficient loners and look at others as intrusive people. Their core dysfunctional belief might be, "I am basically alone." The reasons behind development of such defeating and faulty schemas are not yet fully researched upon. Treatment. Usually people with schizoid personality disorder rarely come for treatment unless it is a response to some crisis such as losing a job or some other extreme issue. Therapy usually starts with making them understand value in social relationships and may also be taught about empathy and understanding others. Thus, they may receive training in social skills development. They are taught to identify a social network, a person or those who would be supportive to them. 3.3.3 Schizotypal personality disorder. Schizotypal personality disorder is characterized by excessive introversion, along with social and interpersonal difficulties. They tend to have perceptual and cognitive distortions, suspicious and odd behavior. Their contact with reality is usually intact, but under extreme stress they may also experience certain transient psychotic symptoms. Schizotypal personality disorder is on a continuum with schizophrenia, but here there is absence of certain symptoms such as hallucinations and delusions. They often come as bizarre to others due to their odd ways of dressing, relating to others and the way they think and behave. They may have ideas of reference and yet may be able to acknowledge the unlikeliness of it. People with schizophrenia too have ideas reference, but they cannot test reality, unlike individuals with schizotypal personality disorder. They may believe in magical thinking or believe that they have magical powers like being a clairvoyant. They may even report unusual perceptual experiences but do not have extreme perceptual distortions like people with schizophrenia. Schizotypal personality disorder has been understood as an attenuated form of schizophrenia. Bizarreness and oddities in thinking, speech and other behaviors are the characteristic features of schizotypal personality disorder. Some aspects of schizotypy such as introversion and neuroticism can be explained through the 5-factor model of personality. However, the aspects related to cognitive and perceptual distortions cannot be explained through the model, especially unusual beliefs and experiences, eccentricity and cognitive and perceptual dysregulation. It is important for mental health professionals to practice caution, especially when dealing with certain cultural practices which may differ from their own and thus may look distorted or may look like an odd behavior before giving a final diagnosis. Box 3.5, DSM-5 Criteria for Schizotypal Personality Disorder. A pervasive pattern of social and interpersonal deficits marked by acute discomfort with, and reduced capacity for, close relationships, as well as by cognitive or perceptual distortions and eccentricities of behavior, beginning by early adulthood and present in a variety of contexts, as indicated by 5, or more, of the following. 1. Ideas of reference, excluding delusions of reference. 2. Odd beliefs or magical thinking that influences behavior and is inconsistent with subcultural norms. For example, superstitiousness, belief in clairvoyance, telepathy, or sixth sense, in children and adolescents, bizarre fantasies or preoccupations. 3. Unusual perceptual experiences, including bodily illusions. 4. Odd thinking and speech, for example, vague, circumstantial, metaphorical, over-elaborate, or stereotyped. 5. Suspiciousness or paranoid ideation. 6. Inappropriate or constricted affect. 7. Behavior or appearance that is odd, eccentric, or peculiar. 8. Lack of close friends or confidants other than first-degree relatives. 9. Excessive social anxiety that does not diminish with familiarity and tends to be associated with paranoid fears rather than negative judgments about self. B does not occur exclusively during the course of schizophrenia, a bipolar disorder or depressive disorder with psychotic features, another psychotic disorder, or autism spectrum disorder. Note: if criteria are met prior to the onset of schizophrenia, add premorbid, for example, schizotypal personality disorder, premorbid. Causal factors. A review of studies has suggested that the prevalence of schizotypal personality disorder in the general population is about 2 to 3% with a moderate heritability. A genetic relationship of schizotypal personality disorder has long been suspected with schizophrenia. It has been found that it is a part of the spectrum of liability for schizophrenia that occurs in first-degree relatives of people having schizophrenia. Teenagers with schizotypal personality disorder are at high risk of developing schizophrenia and / or schizophrenia spectrum disorders. The biological association between the two disorders has been understood by various studies and researches. Both have been found to have a deficit in the ability to visually track a moving target, deficits in ability to sustain attention, deficits in working memory and language abnormalities which could be related to abnormalities in their auditory processing. Another aspect to that has been proposed is that there is a second subtype which is not genetically linked to schizophrenia and is characterized by cognitive and perceptual deficits. It might be linked to history of early childhood trauma and abuse. Low family socioeconomic background and exposure to stressful events could also be the contributors. Treatment. It has been estimated that almost 30 to 50% of the people with schizotypal personality also meet the diagnostic criteria for major depression. Thus, their treatment also involves the ones given to people with major depression. The interest is slowly increasing in looking for treatment methods and strategies for schizotypal personality gradually, as it is also viewed as a precursor to schizophrenia. Some studies have used antipsychotic medication, community treatment and social skills training as a combination to treat people with this disorder. And it has been found that using this approach has either reduced the symptoms or has delayed the onset of later schizophrenia. 3.4 Cluster B personality disorders. The prevailing symptoms of Cluster B are being dramatic, erratic or emotional. We will discuss histrionic, narcissistic, antisocial and borderline personality disorders in this section. 3.4.1 Histrionic personality disorder. Histrionic personality disorder is characterized by exaggerated expression of emotions such as hugging someone fiercely they have just met or crying uncontrollably during a sad movie. Another characteristic feature of this disorder is excessive attention-seeking behavior. Their lively, charming, dramatic and extroverted behavior usually makes them center of attention, and they may feel unappreciated if they are not being attended to by people. But soon people around them get tired of this level of attention they seek for constantly, which usually results in unstable and unsatisfying relationships. Their appearance and behavior are usually found to be very dramatic, theatrical and at times sexually provocative as well. They also tend to be vain, uncomfortable and self-centered when not in limelight, and very much concerned about their looks. They can also be impulsive and can have difficulty in delaying gratification. Speech is often very vague, lacking details and also impressionistic, with a major concern of approval from others. Their cognitive style could be characterized by a tendency to view situations in an absolutistic manner, black and white. The prevalence of histrionic personality disorder in the general population has been estimated to be around 2 to 3%, and some studies also suggest of its prevalence more in women as compared to men. The reasons provided behind this gender difference has been very controversial, as it is suggested that the criteria for histrionic personality disorder encompasses maladaptive variants of female-related traits, mainly such as seductiveness, vanity, overdramatization and too much concern with one's physical appearance. However, there are certain characteristic traits of this disorder which are more commonly found in men, such as excitement-seeking behavior or low consciousness. Some recent researches have pointed towards the influence of some form of bias on the basis of gender in the diagnosis of histrionic personality disorder. Box 3.6, DSM-5 Criteria for Histrionic Personality Disorder. A pervasive pattern of excessive emotionality and attention-seeking, beginning by early adulthood and present in a variety of contexts, as indicated by 5 or more of the following. 1. Is uncomfortable in situations in which he or she is not the center of attention. 2. Interaction with others is often characterized by inappropriate, sexually seductive or provocative behavior. 3. Displays rapidly shifting and shallow expression of emotions. 4. Consistently uses physical appearance to draw attention to self. 5. Has a style of speech that is excessively impressionistic and lacking in detail. 6. Shows self-dramatization, theatricality, and exaggerated expression of emotion. 7. Is suggestible, that is, easily influenced by others or circumstances. 8. Considers relationships to be more intimate than they actually are. Causal factors. Despite its long history, very little research has been conducted to understand the causality behind histrionic personality disorder. It could be perhaps due to the difficulty faced by the researchers in differentiating it from other personality disorders. Some researchers have also pointed towards its diagnosis as invalid and referring it as being dead. Thus, it was recommended to be removed from DSM-5. One hypothesis points out a genetic link with antisocial personality disorder. Lilienfeld and colleagues found that almost 2/3 of people with histrionic personality also met the criteria for antisocial personality disorder. Thus, the idea has been proposed that there might be some common underlying predisposition between the two, or they may be the sex-typed alternative expressions of the same condition expressed as predominantly histrionic personality in women and antisocial personality in men. However, this idea still remains controversial and requires much research further. Histrionic personality disorder may also be characterized by extreme versions of two common personality traits, extraversion and, to a lesser extent, neuroticism. These two have partial genetic basis. People with high levels of extraversion of patients with histrionic personality are found to be high on gregariousness, openness to fantasies and excitement seeking. Their high levels of neuroticism may be involved in depression and self-consciousness aspects. Maladaptive schemas, especially about the need for attention and to validate their self-worth, might also be responsible for the disorder. Their core dysfunctional beliefs may include, if I can't entertain people, they'll abandon me. Treatment. Therapists have tried to deal with the attention-seeking behavior of the people with histrionic personality. For instance, in one of the researches, using a behavioral paradigm, the researchers rewarded the appropriate behavior and interaction of people with traits like histrionic personality and were fined for their attention-seeking behavior. They found significant improvement after an 18-month follow-up. As they usually manipulate people through their charm or emotional tactics, a large part of the therapy goes in focusing at their interpersonal relationships. They are also taught more appropriate and acceptable ways to negotiate in order to get their demands fulfilled. 3.4.2 Narcissistic personality disorder. According to Greek mythology, there was a young hunter Narcissus who remained aloof and arrogant, holding many women in disdain who happened to fall for him. To punish Narcissus for his arrogance, the goddess of revenge, Nemesis, put a spell on him, due to which when he next noticed his reflection in a pool of water, he was enamored by it. Love overtook him. He became entirely absorbed by his beautiful image without realizing that it was actually himself. Psychoanalysts have used the term narcissist to describe those individuals who give a lot of importance to themselves and are preoccupied with receiving attention from others most of the times. Narcissistic personality disorder is characterized by exaggerated sense of self-importance that the individual gives to one's self. Another important feature is preoccupation with seeking attention, admiration and lack of empathy. It can be of two types, grandiose and vulnerable. The defining features of the grandiose type of narcissism are aggression, dominance and grandiosity. Thus, they are known to overestimate their abilities and underestimate that of the others. They have a high sense of entitlement and believe that they deserve it all. They brag a lot about themselves and use constant self-references in order to get recognition, which they usually claim for. They easily take offense and rarely forgive others. Vulnerable narcissists have a fragile sense of self-esteem and they use arrogance and disdain to mask their shame and hypersensitivity towards criticism and rejection from outside. They usually avoid relationships and intimacy due to their fear of rejection and criticism. They might look completely absorbed with their achievements and its fantasies, but they do experience and nurse profound shame about their ambitions. Both the types seem to be associated with high levels of antagonism / low agreeableness, low modesty, arrogance, superiority, feelings of grandiosity, low altruism, and tough-mindedness, lack of empathy. In the case of grandiose narcissist, it is the close relatives and family who are more distressed about their behavior rather than the individual, narcissist, herself/himself. Vulnerable narcissists usually have a high level of negative affectivity. Wink tried understanding how the spouses of people narcissism described them and came to the conclusion that they are bossy, intolerant, cruel, argumentative, dishonest, opportunist, conceited, arrogant, and demanding, and those with high grandiosity were also additionally described as being aggressive, outspoken, hard-headed, assertive and determined, whereas patients high on vulnerability were worrying, emotional, defensive, anxious, bitter, tense and also complaining. Another important aspect of individuals with narcissism is their inability to take other person's perspective, and if they do not receive validation as they wanted or desired, they may turn out to be retaliatory. This disorder may be seen more in men as compared to women. It is a relatively rare disorder, especially in comparison to other personality disorders, with an estimated occurrence of 1% in the population. Box 3.7, DSM-5 Criteria for Narcissistic Personality Disorder. A pervasive pattern of grandiosity, in fantasy or behavior, need for admiration, and lack of empathy, beginning by early adulthood and present in a variety of contexts, as indicated by 5 or more of the following. 1. Has a grandiose sense of self-importance, for example, exaggerates achievements and talents, expects to be recognized as superior without commensurate achievements. 2. Is preoccupied with fantasies of unlimited success, power, brilliance, beauty, or ideal love. 3. Believes that he or she is special and unique and can only be understood by, or should associate with, other special or high-status people, or institutions. 4. Requires excessive admiration. 5. Has a sense of entitlement, that is, unreasonable expectations of especially favorable treatment or automatic compliance with his or her expectations. 6. Is interpersonally exploitative, that is, takes advantage of others to achieve his or her own ends. 7. Lacks empathy, is unwilling to recognize or identify with the feelings and needs of others. 8. Is often envious of others or believes that others are envious of him or her. 9. Shows arrogant, haughty behaviors or attitudes. Causal factors. There is a wealth of theories about narcissistic personality disorder but little empirical research in comparison. Kohut believed that it arises mainly from the failure of parenting, wherein parents fail to model empathy in the early developmental stages of the child. Thus, the child, and later as an adult, gets tangled in the endless search for this ideal person who would meet the unfulfilled empathic needs. It has also been found that grandiose narcissism is not generally associated with childhood abuse, neglect or poor parenting, but perhaps with parental overvaluation. On the other hand, vulnerable narcissism is associated with emotions, physical and perhaps sexual abuse and intrusive, controlling or cold parenting styles. Lusk suggested that increasing prevalence of narcissism is a consequence of large-scale social changes with emphasis on characteristics like individualism, competitiveness, hedonism and ambition. Treatment. For people with narcissistic personality disorder, both the number of studies carried out and the success report gathered is limited. Here, the main focus of the therapy is grandiosity. After which attention is also paid to hypersensitivity to evaluation and lack of empathy for others. Relaxation techniques are used for such individuals, which can be helpful for them in accepting and handling the criticism. 3.4.3 Antisocial personality disorder. People with antisocial personality disorder, ASPD, are found to be the most puzzling and intriguing of the individuals that the clinicians would see in their practicing career. They are characterized by their tendency to persistently disregard and violate social norms and rights of others, with a combination of deceit, aggression and antisocial behavior and activities. They lack ethical or moral development and have no remorse or loyalty towards anyone. Robert Hare is considered to be the pioneer in studying people with this disorder and describes them as social predators who charm, manipulate, and ruthlessly plow their way through life, leaving a broad trail of broken hearts, shattered expectations, and empty wallets. Completely lacking in conscience and empathy, they selfishly take what they want and do as they please, violating social norms and expectations without the slightest sense of guilt or regret. They tend to be impulsive, deceitful and irresponsible as well. Lying and cheating is their second nature, making it difficult for them to distinguish between truth and lies to reach their goals. Almost 60% of the people with antisocial personality disorder are found to have substance abuse as well. Cleckley identifies a constellation of 16 characteristics to define psychopathic personality. Hare and colleagues build on it to develop a 20-item checklist that serves as a major assessment tool. 6 of which are included in his revised psychopathy checklist, PCLR1. Glibness / superficial charm, 2. Grandiose self-worth, 3. Need for stimulation, 4. Pathological lying, 5. Conning / manipulation, and 6. Lack of remorse. There are 2 dimensions of psychopathy: A, affective and interpersonal core, B, behavioral dimension. The affective and interpersonal core consists of traits such as lack of remorse, callousness, glibness, lack of empathy, charm, etc., while the behavioral dimension focuses mainly on the behavior, including impulsivity, socially deviant lifestyle, poor and irresponsible behavior, parasitic lifestyle, etc. DSM mainly focused on the observable behaviors as opposed to personality traits so that the clinicians could reliably agree on the diagnosis. The basic logic behind this is that it is difficult to assess someone for a trait of manipulation, but comparatively easier to see if the individual is engaged in certain behaviors such as repeated fighting or stealing. Some of the characteristics of antisocial personality disorder are described as follows: inadequate conscience development. Can understand ethical values only at a verbal level. Intellectual development is normal but conscience development is stunted. Affective and interpersonal dimension is positively related to verbal intelligence, but antisocial dimension is negatively related to intelligence. May act out tensions and then worry them. Irresponsibility and impulsive behavior. Total disregard for needs, rights and well-being of others. High on thrill-seeking, deviant and unconventional behavior. Rarely forego immediate pleasure for some future gain. Occurrence of alcohol, or any other substance dependence and abuse. Elevated rates of suicide attempts. Rejection of authority. Do not follow social norms and rules. Difficulty with educational and law enforcement authorities. Behave as if immune to the consequences of their action. Ability to impress and exploit others. Very charming, win friends easily. Good sense of humor and optimistic outlook. Frequent liar. May seem sorry when caught in the act but are not so. Good insight into other people's needs and weakness. Find excuses readily for their conduct, usually projecting blame on others. Inability to maintain good relationships. ability to win liking of others initially but rarely keep close friends and relationships. Irresponsible, cynical, unsympathetic, egocentric, ungrateful and remorseless. Cannot understand love. Violence towards family members is common. Manipulative and exploitative in their sexual relations. Considered as a menace for family and society. Results from long-term follow-up researches show that many adults with psychopathy or antisocial personality disorder had conduct disorder as children. It has been found that the chances of having adult antisocial personality disorder increase if the child has had a history of both conduct disorder and attention deficit/hyperactivity disorder. A major difference between the two is that lack of remorse is there in antisocial personality disorder but not in the criteria for conduct disorder. Box 3.8, DSM-5 Criteria for Antisocial Personality Disorder. A pervasive pattern of disregard for and violation of the rights of others, occurring since age 15 years, as indicated by 3, or more, of the following. 1. Failure to conform to social norms with respect to lawful behaviors, as indicated by repeatedly performing acts that are grounds for arrest. 2. Deceitfulness, as indicated by repeated lying, use of aliases, or conning others for personal profit or pleasure. 3. Impulsivity or failure to plan ahead. 4. Irritability and aggressiveness, as indicated by repeated physical fights or assaults. 5. Reckless disregard for safety of self or others. 6. Consistent irresponsibility, as indicated by repeated failure to sustain consistent work behavior or honor financial obligations. 7. Lack of remorse, as indicated by being indifferent to or rationalizing having hurt, mistreated, or stolen from another. B. The individual is at least age 18 years. C. There is evidence of conduct disorder with onset before age 15 years. D. The occurrence of antisocial behavior is not exclusively during the course of schizophrenia or bipolar disorder. Causal factors. In a classic study done by Crow, children of criminal mothers who were later adopted by other families were compared with adopted children of normal mothers. These children were separated from their mothers very early, thus ensuring that environmental factors from biological parents had lesser or no impact. It was found that adopted children of criminal mothers had significantly higher rates of conviction than the others. Another important finding presented was that the children of criminal mothers who had spent more time in the orphanages later became criminals than either the adopted children of normal mothers or adopted children of criminal mothers, who did not spend much time in the orphanages. Thus, pointing towards interaction between genetics and environment. Genetic factors may play an important role in the presence of certain environmental cues and influences and vice versa. This has further been researched upon and validated. Early theoretical work in this area has suggested two major hypotheses: under-arousal and fearlessness. According to the under-arousal hypothesis, people with antisocial personality have abnormally low levels of cortical arousal. It could also be the primary cause of their risk-taking and further antisocial behavior. In order to boost their low levels of arousal, they may seek stimulation. Rain and colleagues found that future criminals, assessed when 15-year-old due to their antisocial behaviors, had lower skin conductance and heart rate during rest periods and also slow brain wave activity, which was indicative of low arousal. On the other hand, the fearlessness hypothesis says that the psychopaths have a higher threshold for experiencing fear than most of the other people. According to Jeffrey Gray, there are three major brain systems that influence our learning and emotional behavior: the behavioral inhibition system, BIS, the reward system, and the fight-forward/flight system. BIS and the reward system have been used to explain the behavior of people with psychopathy. BIS is located in the septo-hippocampal system involving both serotonergic and noradrenergic neurotransmitter systems. It plays a role in our ability to stop or slow down in the wake of impending punishment or novel situation. The reward system is responsible for our behavior when we are approached with positive reward associated with hope and relief. Malfunctioning of these two systems is very much evident in the case of psychopaths. It has been hypothesized that the imbalance between these two systems may make fear and anxiety as produced by BIS less apparent and positive effect associated with reward system more prominent. Thus, psychopaths do not become anxious while committing the acts that are considered antisocial. As a result of several studies, the researchers hypothesized that as soon as a psychopath sets his eyes on a reward goal, they do not deter, unlike non-psychopaths, despite the signs that the goal could be no longer available or achievable. This could be due to their reckless, daring and thrill-seeking behavior. An interesting research also suggested that the aggression in children with antisocial personality may also escalate due to their interaction with their parents. It was also found that in order to restore peace in the house and perhaps also in the relationship, many times parents give in to the demands of the child, eventually promoting their behavior of fighting and not giving up at any cost. If this coercive family process gets combined with factors such as less parental involvement, poor or less effective child monitoring activities, it may help in maintaining the aggressive behavior. Some evidence from adoption studies have also suggested that shared environmental factors could have a very important role in the etiology of antisocial personality disorder. Treatment. One of the major issues in treating ASPD is that they are capable of manipulating even their therapists. Thus, there are very few documented successful treatment cases of ASPD. Mostly, therapists agree with detaining or imprisoning them for their antisocial acts so that any future such acts can be avoided. Precaution is something that has been mainly encouraged here so that the high-risk children can be identified and treatment can be attempted on them before they enter adulthood. One of the common strategies used is to train parents of these children by teaching them how to identify these behavioral problems and using a reward-based system to encourage pro-social behavior. However, family dysfunction, poor socioeconomic status or even high conduct-related issues with the child may risk the treatment or may result in dropout from the treatment. Drugs such as lithium and anticonvulsants that are used to treat bipolar disorder have been found to be successful to some extent in dealing with aggressive/impulsive behavior, but the evidence is not solid to make concrete conclusions. Cognitive behavioral therapy mainly targets social perspective taking, helping them in increasing self-control, increasing victim awareness, teaching anger management skills, changing antisocial attitudes and even curing their drug addiction. It is important to note here that when dealing with ASPD, therapists are actually dealing with the complete lifestyle of an individual rather than a few subsets of behavior. It has also been found that their behavior can be managed when they are in the prison or the facilities where treatment is being administered, but does not generalize once these people go back to the real outside world. 3.4.4 Borderline personality disorder. The term borderline was originally used to refer to the people who had a condition which could be termed as being between neurotic and psychotic borderline. However, later this explanation was termed as schizotypal personality disorder, which is biologically also related to schizophrenia. The current diagnosis of borderline personality disorder, BPD, is not biologically linked to schizophrenia. The characteristic pattern of people with BPD is impulsivity and instability in self-image, moods and even in relationships. This affective instability is usually manifested by extreme and intense responses to any of the environmental triggers without thinking about any sort of long-term consequences. They can also go through rapid shifts in emotions from one to another. Their sense of self has been described as fragmented. They have highly unstable relationships, perhaps due to their unstable self-image and affective instability, usually ending in disappointment and anger. Though, it's also important to note here that their fear of abandonment is also very strong, and thus they try to avoid it as much as possible. These people are also prone to get into self-destructive and erratic behavior. Suicide attempts can also be a part of the clinical picture. It could be manipulative, and some may also end up completing the act. Self-injury or self-mutilation is a common feature amongst people with BPD, but again it has to be understood with caution that everyone or anyone engaging in any kind of self-harm do not have BPD. Such a behavior could be performed to relieve oneself of anxiety or as a result of dysphoria. With these behavioral and affective symptoms, there are cognitive symptoms as well in the patients with BPD. There can be very short periods when they may have psychotic-like symptoms such as losing contact with reality, delusional experiences, or even hallucinations. This particular personality disorder leads to significant social, occupational and academic functioning, and is also seen to commonly co-occur with mood disorders, anxiety disorders, eating disorders and substance use as well. Box 3.9, DSM-5 Criteria for Borderline Personality Disorder. A pervasive pattern of instability of interpersonal relationships, self-image, and affects, and marked impulsivity, beginning by early adulthood and present in a variety of contexts, as indicated by 5 or more of the following. 1. Frantic efforts to avoid real or imagined abandonment. Note: do not include suicidal or self-mutilating behavior covered in Criterion 5. 2. A pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idealization and devaluation. 3. Identity disturbance, markedly and persistently unstable self-image or sense of self. 4. Impulsivity in at least 2 areas that are potentially self-damaging, for example, spending, sex, substance abuse, reckless driving, binge eating. Note: do not include suicidal or self-mutilating behavior. 5. Recurrent suicidal behavior, gestures, or threats, or self-mutilating behavior. 6. Affective instability due to a marked reactivity of mood, for example, intense episodic dysphoria, irritability, or anxiety, usually lasting a few hours and only rarely more than a few days. 7. Chronic feelings of emptiness. 8. Inappropriate, intense anger or difficulty controlling anger, for example, frequent displays of temper, constant anger, recurrent physical fights. 9. Transient, stress-related paranoid ideation or severe dissociative symptoms. Causal factors. It has been found that genetic factors may play an important role in development of BPD. One of the major aspects supporting this view is that both affective instability and impulsivity that are prominent manifestations of people with BPD are partially heritable. The genes involved in regulation of the neurotransmitter dopamine may also have a role to play in BPD, along with lower serotonin levels. The low serotonin level might be a reason why they are not able to stop their impulsive behaviors. Structural brain abnormalities studies show that patients with BPD may have reductions in the volume of hippocampus and amygdala, perhaps thus showing more aggression and impulsivity. Some of the retrospective psychosocial studies have pointed towards the role of childhood trauma, adversity and maltreatment. Paris had offered a diathesis stress theory to understand the probably causality of BPD. People with high levels of impulsivity and affective instability may have a diathesis which may lead to the development of BPD, but in the presence of certain triggers and risk factors such as trauma, parental neglect, failure, or some kind of loss. In the presence of such specific factors, an individual who is already affectively unstable may become labil or dysphoric. Coupled with impulsivity, they may also act out on it to cope up with their negative effect. Weakening of the family structures may be a major reason of increasing prevalence of BPD in today's times. Treatment. It has been found that people with BPD seek for treatment much more than ASBDs or other disorders. Anticonvulsants and antipsychotics are usually found to be effective in treating the core symptoms of BPD. However, the efforts become slightly complicated due to their drug abuse or suicide attempts. Marsha Linehan has developed an approach called as dialectical behavior therapy, DBT, which has been found to be quite successful in these cases. In this treatment, priority is given to the suicidal behavior, then the ones that interfere with the therapy and its continuation, followed by the behaviors which may interfere with the quality of life of the individual. Patients are taught to regulate their emotions and handling problems on an everyday basis. They are also given treatment similar to those of patients with PTSD, as that they can douse off the fear associated with traumatic events. Then they are made to trust their own responses more than depending on other people for constant validation by helping them in visualizing themselves where they are not reacting to the criticisms negatively. DBT has been found to be an effective therapy which is impactful in helping people with BPD. 3.5 Cluster C personality disorders. Cluster C personality disorders comprises of 3 personality disorders: avoidant, dependent and obsessive-compulsive. The common characteristics are anxiety and fearfulness. To help understand the mentioned disorders, let us look at the clinical features, causal factors and treatment of each disorder. 3.5.1 Avoidant personality disorder. Extreme social inhibition and introversion are characteristic patterns of avoidant personality disorder. Due to this, they have a pattern of limited social relationships and are reluctant in social interactions. They do not seek out for other people as they are scared of being criticized or rebuffed by them. However, this does not mean that they do not desire affection. They often feel lonely and bored. Meehan and Martinez believed that it is important to distinguish between individuals who are asocial as they are apathetic, have flat affect, indifferent towards criticism and not interested in interpersonal relationships, diagnosis comparable to schizoid personality disorder, and those who are asocial because they fear rejection and thus are interpersonally anxious. The latter category is the one that fits the diagnosis of avoidant personality disorder. Unlike people with schizoid personality disorder, they do not enjoy their aloofness. Due to their inability to relate to others, they may have low self-esteem and may even be associated with depression. Researchers have concluded that people with avoidant personality disorder show generalized shyness or nervousness and may also avoid novel situations and even emotions. This can also include avoiding positive emotions. They may also exhibit their inability in experiencing pleasure. Another tricky distinction is between social phobia and avoidant personality disorder. Some investigators have concluded that avoidant personality could be simply a more severe manifestation of generalized social phobia. Box 3.10, DSM-5 Criteria for Avoidant Personality Disorder. A pervasive pattern of social inhibition, feelings of inadequacy, and hypersensitivity to negative evaluation, beginning by early adulthood and present in a variety of contexts, as indicated by 4 or more of the following. 1. Avoids occupational activities that involve significant interpersonal contact because of fears of criticism, disapproval, or rejection. 2. Is unwilling to get involved with people unless certain of being liked. 3. Shows restraint within intimate relationships because of the fear of being shamed or ridiculed. 4. is preoccupied with being criticized or rejected in social situations. 5. Is inhibited in new interpersonal situations because of feelings of inadequacy. 6. Views self as socially inept, personally unappealing, or inferior to others. 7. Is unusually reluctant to take personal risks or to engage in any new activities because they may prove embarrassing. Causal factors. Avoidant personality disorder may have its roots in an innate inhibited temperament due to which the newly born infant and child may feel timid or even inhibited in a new or an ambiguous situation. Some of the studies also show that genetic vulnerability for avoidant personality disorder can also be seen in people with social phobia, if not fully then at least partially. Fear of rejection and negative evaluation has also been found to be moderately heritable along with traits such as introversion and neuroticism, and all these are prominent in people with avoidant personality disorder. There is also a possibility that these biologically based inhibited temperaments may actually serve as a diathesis, and when one faces experiences such as emotional abuse or rejection as a child, it may eventually lead to avoidant personality disorder. Treatment. The problems experienced by people with avoidant personality are similar to those with social phobias, and that is why a similar set of techniques is used for both. Behavioral intervention techniques for social skill management and anxiety are very helpful here as well. It is important to note that the therapeutic alliance is an important predictor in avoidant personality disorder for the success of treatment. 3.5.2 Dependent personality disorder. Dependent personality disorder is characterized by an individual's extreme need to be taken care of, thus pointing towards her/his submissive and also clingy behavior. They may show fear of being separated from others, just being alone, as they find themselves inept or incompetent. They may not get angry with others, or find fault in others due to their fear of being separated from others or losing their support. This is indicative of the fact that such people may remain in physically or psychologically abusive relationships. Thus, they usually carve their lives around other people, giving lesser importance to their own needs and not having confidence in themselves. They take decisions with the help of others. In terms of the 5-factor model, dependent personality disorder is associated with prevalence of neuroticism and agreeableness. The prevalence of dependent personality disorder has been seen in women more than men. This not just due to the gender bias in the diagnosis, but mainly because of the higher prevalence of traits such as neuroticism and agreeableness in women, which are also characteristic features of dependent personality disorder. Some of the features of dependent personality disorder also overlap with that of histrionic, borderline and avoidant personality, and a clear understanding of the three necessary is to make a diagnosis. The difference between avoidant and dependent personality has already been highlighted above. Similarly, both borderline and dependent personalities fear abandonment by people around them, but their reactions to it can be different. For instance, people with borderline personality may react with feelings of emptiness and rage, whereas people with dependent personality may initially become submissive and then may seek for new relationships. Box 3.11, DSM-5 Criteria for Dependent Personality Disorder. A pervasive and excessive need to be taken care of that leads to submissive and clinging behavior and fears of separation, beginning by early adulthood and present in a variety of contexts, as indicated by 5 or more of the following. 1. Has difficulty making everyday decisions without an excessive amount of advice and reassurance from others. 2. Needs others to assume responsibility for most major areas of his or her life. 3. Has difficulty expressing disagreement with others because of fear of loss of support or approval. Note: do not include realistic fears of retribution. 4. has difficulty initiating projects or doing things on his or her own, because of a lack of self-confidence in judgment or abilities rather than a lack of motivation or energy. 5. Goes to excessive lengths to obtain nurturance and support from others, to the point of volunteering to do things that are unpleasant. 6. Feels uncomfortable or helpless when alone because of exaggerated fears of being unable to care for himself or herself. 7. Urgently seeks another relationship as a source of care and support when a close relationship ends. 8. Is unrealistically preoccupied with fears of being left to take care of himself or herself. Causes. Factors. Genetic influence has been found to be modest in the case of dependent personality disorder. Traits such as neuroticism and agreeableness, prominent in dependent personality disorder, have a genetic component to it. There is also a possibility that at least partial predisposition to dependence and anxiousness may make them prone to negative impact of authoritarian and overprotective parenting, thus reinforcing their dependent behavior. As described by cognitive researchers, people with dependent personality disorder, the underlying schemas about themselves might be maladaptive and thus they may have a core belief about them being weak, incompetent and requiring others for their survival. This has also been supported by recent researches. Treatment. Majority of the treatment literature in this case is descriptive. They look like ideal patients because of their attentiveness towards the therapist and eagerness to share their problems, but they are eventually found to be compliant to everything the therapist says. Their submissiveness becomes a major hindrance in the therapy. Their core belief about themselves being weak and dependent on others is challenged using cognitive behavior therapy, and the urge to be confident, independent and take decisions on their own is instilled in them. 3.5.3 Obsessive-compulsive personality disorder. People with obsessive-compulsive personality disorder, OCPD, show an excessive concern with maintaining order and control. They exhibit perfectionist tendencies by paying attention to rules, orders and schedules. Their perfectionism can be dysfunctional to the extent that they may never finish their projects as they are too preoccupied with trivial details and thus utilize their time poorly. They might be too devoted to work to the extent that they may have difficulty in doing anything for leisure and entertainment. Others may view them as rigid or cold as they usually don't delegate tasks to others. It is important to note that unlike people with obsessive-compulsive disorder, OCD, they do not have obsessions or follow compulsive rituals. Instead, people with OCPD have lifestyle characteristics of high neuroticism, inflexibility, high conscientiousness and also perfectionism. It has also been found that only about 20% of the people with OCD have a comorbid diagnosis of OCPD. In fact, people with OCD are more likely to be diagnosed with either avoidant or dependent personality disorder. Causal factors. As per the biological dimensional approach of cloning, there are 3 personality dimensions that have been discussed: novelty seeking, harm avoidance and reward dependence. People with OCPD are seen to have lower levels of novelty seeking and reward dependence but a higher level of harm avoidance. Some research has also confirmed that OCPD traits show a modest genetic influence. Personality trait-based theories have discussed that people with OCPD are high on conscientiousness. This could also be a reason for their perfectionist tendencies, highly controlling behavior or extreme devotion towards work. Treatment. Therapy usually focuses on their need for keeping everything in control and order. They are helped by teaching them relaxation and distraction techniques to keep the compulsive thoughts away. Cognitive behavior therapy has been found to be effective with patients of OCPD. Box 3.12, DSM-5 Criteria for Obsessive-Compulsive Personality Disorder. a pervasive pattern of preoccupation with orderliness, perfectionism, and mental and interpersonal control, at the expense of flexibility, openness, and efficiency, beginning by early adulthood and present in a variety of contexts, as indicated by 4 or more of the following. 1. Is preoccupied with details, rules, lists, order, organization, or schedules to the extent that the major point of the activity is lost. 2. Shows perfectionism that interferes with task completion, for example, is unable to complete a project because his or her own overly strict standards are not met. 3. Is excessively devoted to work and productivity to the exclusion of leisure activities and friendships, not accounted for by obvious economic necessity. 4. Is over-conscientious, scrupulous, and inflexible about matters of morality, ethics, or values, not accounted for by cultural or religious identification. 5. Is unable to discard worn-out or worthless objects even when they have no sentimental value. 6. Is reluctant to delegate tasks or to work with others unless they submit to exactly his or her way of doing things. 7. Adopts a miserly spending style toward both self and others. Money is viewed as something to be hoarded for future catastrophes. 8. Shows rigidity and stubbornness. 3.6 Socio-cultural causes of personality disorders. According to some of the researchers, there is less variation in personality disorders across cultures than within cultures. This could be due to the fact that all the cultures share the basic 5 personality traits. Paris noted that certain personality disorders have increased in the American society in past few years. This could be due to the changing cultural priorities with time. For instance, narcissistic personality disorder has been found to be more prevalent in Western societies, and a probable reason for it could be the emphasis on personal success and ambition. It has also been suggested that as emotional dysregulation and impulsive behavior has increased over the years, especially since World War II, it may have some association with the increased prevalence of borderline and ASPDs over a period of time for the same time frame. It may have its connections with breakdown of traditional family systems and various other social structures. Thorough research in this area is required before making any further claims. 3.7 Let us sum up. Now that we have come to the end of this unit, let us list all the major points that we have already learnt. Personality disorders indicate an inflexible and distorted behavioral pattern resulting in maladaptive ways of perceiving, thinking and relating to others and their environment. DSM has categorized personality disorders into 3 clusters, and the validity of this categorization has been questioned. DSM-5 has not used this categorization, but this has been used due to commonalities shared by disorders categorized under each cluster. Cluster A includes paranoid, schizoid, and schizotypal personality disorders. The characteristic features of this disorder are eccentricities or oddities. Genetic and biological causes are implicated in schizotypal personality disorder, but the research around causes of paranoid and schizoid disorders is relatively less. Cluster B includes histrionic, narcissistic, antisocial and borderline personality disorders. People falling in this cluster are found to be emotional, erratic and dramatic. Research in the area of histrionic and narcissistic personality is very scant, but certain biological and psychosocial factors have been researched upon to understand the causality of borderline and antisocial personalities. Cluster C comprises of avoidant, dependent and obsessive-compulsive personality disorders. This cluster characterizes fearfulness, tension, shyness and anxiety-based symptoms. Inhibited temperament may increase the risk for avoidant personality, and those high on traits such as neuroticism and agreeableness may increase risk for dependent personality disorder, especially when faced with authoritarian and overprotective parenting styles. In the present unit, all the three clusters were discussed in detail along with their causal factors and treatment.